Hanji. So I'll get back to the same case that.
So they've moved us to the next room.
Do you want to update us on what has happened?
So the hemodynamics actually worsened in that period of time despite the balloon pump. So he started getting PVCs, and we were all about to intubate because the saturation had dipped to 70%. But I decided to go ahead with the LAD first because that was a culprit lesion. I thought that if I don't open it now, the ischemia will kill him. And so we quickly stented with very adverse hemodynamics to the LAD and restored flow. The saturation without ventilation has improved to 98%. Augmented pressure is now 120. So there we are now. This is the balloon. This is the stented segment. You see the distal LAD flow is very good. And the patient is feeling much better. The saturation is about to 98%.
So was it restoring flow?
Yeah, restoring flow to the LAD was the key.
Did he respond immediately after restoring flow?
Yes, immediately. The heart rate was.
I think that gives a very clear message that once there is ischemia, you immediately act and relieve the ischemia, and the hemodynamics would improve.
So his pressure is now 110. Saturation is 98%. And he's feeling much comfortable. The QRS, which was wide, has become narrow. So now I'm doing a post-dilatation. We'll take an OCT after this.
All things are looking much better.
Agramed, bolus.
Agramed.
Did the diagonal branch stay open with the stent? I didn't see the picture.
The diagonal branch is showing a slow flow. I'll doing a pot. I'll go to the diagonal after this. $14. Go. 14. 16. Down. So we're doing a pot to the proximal part of the stent with a 3.5 balloon. I had taken a 3 into 26 Onax. The patient is much comfortable now. He was coughing and the saturations were dropping, so I had actually thought that I'll improve his hemodynamics, but it was the opening the LAD which improved him. Elio Caudal.
You know, it's interesting because some of these cases, if the patient, you get to them early and quickly reperfuse, you can reverse the whole cycle. But there are others that present when they're already in shock, and we try to reperfuse them quickly to reverse things, but that often doesn't because their ventricle's already taken a hit. So it's just a matter of if you can do it very, very rapidly or it happens in lab, that works. Otherwise, you have to support the pump before you do anything else.
I know we're getting a little ahead of ourselves, but the issue of complete revascularization in this case. So this guy, the LAD was probably the culprit. His hemodynamics have improved. He's got a tight circ. He's on a balloon pump. Do you fix the circ in this setting, or do you do it later?
So, in my opinion...
You know, I think if he had the hit that he took and he was that sick and then he's recovered, I would think I would go after the LED diagonal and then stop in the balloon pump type of scenario. But with greater degrees of support, so for instance, if you have something like an Impella or the patient's on ECMO or otherwise, you probably would fix everything at once because the patient is unlikely to get a lot worse, and then you'd be done at that point. Sorry to interrupt. Go ahead. So that was your thought, to
Allocleaning.
fix the LED diag and then stop?
Yeah, my thought is that I'm going to do LED diagonal today and then go later. Test.
I think in smaller centers where there's not enough volume, probably even putting a balloon pump and calling the surgeon at the time of when he was suddenly going down is an option. You could just put a balloon pump and call the surgeon for complete revamp.
Yeah, as long as they're willing to do it quickly, because the balloon pump may stabilize a little bit, but once they truly develop shock, it becomes much harder to keep the patient okay in that situation. But I agree. The balloon pump has been maligned in the UESC guidelines now. It's class 3 on the basis of IVP shock.
Cranium.
But the reality is that, especially acutely, it can get you out of bad situations.
Check. So when I had the balloon pump in, he hardly improved. It's only the stenting of the LED which helped.
Yeah.
So
Right.
we saw that the distal LED flow was slow, so that
Which
was...
wire is this?
This is a whisper wire. If it doesn't go, I move to a fielder. Fielder nikalo.
Filter.
Dr. Balbir, we have 7 minutes to finalize. 7 minutes left only for your transmission, sir.
Yeah.
For your side.
Right, the diagonal.
Don't touch all these things.
So I have to get to the diagonal.
Yeah, so these can be pretty tough to manipulate.
Trap the wire into the diagonal, then you would not have lost the diagonal.
You know
You
that,
can sometimes still lose it, but then at least you know where to go.
but that time it was a life-saving situation.
If you have entrapped the,
Right.
yeah, that's,
Yeah, that's a good point. I mean, it's different. At that point, you're just trying to restore flow.
otherwise, definitely entrap the wire.
Right. In an elective situation, you need to keep a wire in the side branch. But in an emergency situation, we always protect the LAD first and then think about now his blood pressure is 110, which is much better than 44. Yeah.
Before putting the stent,
Right.
you just put at least put the wire so that if you entrap the diagonal, it will not be lost.
Yeah, I mean, I think that
Wire is there, never.
Dr. Yadav, the
the
situation...
strategy is if you balloon the LAD and restore flow, then you buy yourself some time.
I wouldn't buy that strategy.
Once you dilate it, the LED ischemia improved. Before putting the stent, you put the wire so that at least diagonal will not go.
Well, Dr. Yadav, I don't think
So
we
he
had...
should be able to
But
get it.
whatever you did is okay in this situation.
Yeah, and he should be able to.
Dr. Balbir, we have 3 more minutes with you
Yeah,
before
so-
we go to the next room.
So my
And I
question...
think you have done a perfect job here getting the LAD first open.
because saturation had dropped to 65. We were almost thinking of ventilating him, and I had no choice but to stent the LED. I couldn't have waited on a balloon after that and tried to wear the diagonal. I will get this diagonal back, I know that. But at that time, I could have lost the patient.
Yeah, he'll be able to get it. You'll be able to get it.
So,
For these situations, if you have challenges, you can bring a microcatheter down to help you. There are catheters that are shaped that way. There are other catheters that you can deliver the wire through. All of those can be useful in these types of circumstances. One thing I would not advise doing is sometimes people like exchanging the wire, so they take the LED wire and they flip that into the diagonal. That's a technique the Europeans have used. And especially in a case like this where the patient already had slow flow in the LED, he can still have other things happen. It's just better to take a new wire and to wire it and not to give up your LED wire position. If you have difficulty delivering the wire down the LED, then do what he did, which is to do the pot first to make sure that the stent is opposed. You'll then be through it and then can continue.
Even not able to cross, nothing is going to happen. Maybe small in part.
Right. If you give, I think, maintain him with adenosine and 2B3A and bring him back in 2 days, I'm pretty confident the flow in the diagonal will be restored, and you can fix both the circumflex at that time as well as the diagonal if need be.
I don't know though. I mean, when they're completely occluded with no flow, they usually end up occluded.
Loss occurs when there is a dissection to the lesion site, which after a stent, mostly you will not able to re-enter. If there is no dissection, you can re-enter into the site. Even if it goes away. Flap closes the origin of the site.
So Dr. Balbir will be leaving you here.
Yeah, thank you. So
thank you very much for showing us this complex patient who suddenly deteriorated, and you have saved him by putting the LAD stent, and then I think you have now enough time offline to work on the diagonal, and if you will choose to work on the circumflex as well. But as the panel said, probably the circumflex will be done, should be done at a separate setting if he's not unstable.
yeah, thank you very much.
Thank you once again, and for a great demonstration of taking care of this unstable patient.
Yeah, so can you hear me?
Yeah, we can.
So I crossed the diagonal with a Fielder XT wire. There was no flow at the time of crossing the wire. I didn't have to use any microcatheter or any such thing. I would managed it with the Fielder XT wire. And after that, next, can you see the cine?
Yeah, flow looks much better.
Next. So after that, I dilated with a 2O balloon. You see, I've just kept it at the ostium and dilated it with this at 6 atmospheres. Next. And the flow in the diagonal is pretty good as the LED. So I will do one more dilatation with a 2 millimeter balloon for 1 minute, and then decide whether I want to do a tap or not.
I think that's a great demonstration. For the audience, one thing to mention with the microcatheter situation is that Fielder XT, especially at that distal position, in his expert hands, this is going to be fine. But for most of us, we train with fellows and everything, we sort of have a rule, we'll always switch that out for a workhorse wire, because especially as you're pulling balloons out or things are moving up and down, that goes forward and then you have a distal wire perforation that you have to deal with.
So
that's the advantage of going with a microcatheter. You can push it down, take it out, trap it, and then be from there.
Okay, so I have a trick to avoid that. You see the distal loop on my wire on the Fielder XT? The tip has now turned into a loop. So loop is very unlikely to cause perforation.
Yep. Yeah, we can't actually, I can't appreciate it as well, but if you have a loop on the XT, that is great. And that will usually stay if you have a true loop at the end there. And so
Yeah, that's
I agree
what we
completely.
always do with even with a whisper wire. When you use whisper wire to cross this, we make a terminal loop so that it doesn't slip forward and doesn't cause perforation. Otherwise, these are notorious wires to cause wire perforation.
I mean, it's those tricks that are key, though, because you can take this case and you can, as Ajay is saying, have a real problem. Maybe we can talk for a second what pharmacology to use in this patient, what you're using, and what should be used after.
Okay, so I had started with anyone.
So I
Six.
Go ahead, please.
So, in these patients, I always go to 2B3A whenever there is a side branch occlusion, either in this patient or even in the previous room when we are doing complex procedures. And if there is definitely loss of flow, I would choose 2B3A on top of dual antiplatelet therapy, which includes in our institution ticagrelor and aspirin. And heparin is the antithrombin that we use.
You know, it's interesting. I think that definitely you could do that. I would have the opposite, and for me, especially given the fact that it's a femoral case, a balloon pump was given as well. The chance of a bleeding complication, in my mind, is much higher than the chance of having a thrombotic or ischemic complication now that he's got the diag back open. So for me, I think you clearly give more potent P2Y12 inhibitor, but in the lab, I would avoid using a 2B3A in this case. But I totally see it both ways. You can do either.
Maybe I should. So we started using very short infusions of tirofiban. Most of our patients are radial, and we reserve the groin only for balloon pumps or impellers. And so in that situation, I think we haven't seen any increased risk of bleeding with short infusions of 2B3A. I think we're getting a signal to close.
One quick question though. You started this case femoral from the beginning. Is that your routine in your practice?
Okay.
But if you started this radial, then you had to convert to femoral for the balloon pump. Obviously, you get femoral access for the balloon pump.
Right. So I started as a femoral because
Yeah, but in case we need GP2B3 inhibitors. Sorry.
Go ahead. Sorry.
Go ahead, Balbir.
So I started as a femoral case because this patient underwent a radial angiogram very recently. And second, with this bifurcation, with circumflex bifurcation, with RCA, I was very keen that in an unstable patient, he had chest pain yesterday also. I was not keen to start a radial procedure.
I think, Dr. Balbir, that is a very nice demonstration of this procedure complex. Yes, so we're going to lose our satellite link in a few minutes. And any last words from our panel?
No, it looks great.
Great. Yeah, I think there's a wonderful demonstration in an unstable patient how to relieve the patient of his ischemia and bring back the hemodynamics, and that's what he has shown.
I agree. Excellent example. Staying calm in a scenario where things are getting hairy is one of the hallmarks of a truly good interventionalist, and is an excellent demonstration of that. Thank you very much.
Thank you very much.
Absolutely.
Thank you very much.